My name is Philip Ferrone. I'm a partner at Vitreoretinal Consultants of New York, which is a large retina-only practice group, and I've been practicing retina for 30 years. Focus on children and inherited retinal disease, as well as trauma, complicated retinal detachments in both adults and children. And that's been an interest of mine and a passion of mine. And Stargardt's disease, and I'm also a professor of medicine at Hofstra School of Medicine here in New York. Stargardt disease I've been seeing these patients for many years, and it's been an interest of mine for a long time. There's no good treatment up to this point. So you see these young kids come in and they have very compromised disease. And they're really, again, up to this point, there hasn't been anything that we can offer them. And you just slowly see these children lose ground and young adults lose ground, which is very frustrating for everyone, the parents, the patient, and us as caretakers. And Stargardt's disease has an incidence in the US of about 1 in 8 to 10,000 patients and affects approximately 43,000 patients in the US and up to 1 million patients worldwide. It's caused principally by a defect in the ABCA4 gene, and it's inherited autosomally recessively, which means if you have two parents that are carriers, don't manifest the disease, but have an abnormal ABCA4 gene, 1 in 4 of their children will manifest the actual disease. So it's not uncommon, and unfortunately, it's a bit too common with no treatment up to this point that's been helpful for these patients. Well, first of all, I think in children, it's difficult to diagnose most things, right? Because they're not as cooperative, even for imaging or exams. When you're shining a bright light in their eyes or ask them to hold still for a picture, it's difficult for them. So that's one cause of a delay in getting these patients diagnosed. The other is the degree of familiarity with Stargardt's disease is not ideal. In medical school or residency, we learn about Stargardt's disease, but it's really a classic kind of appearance of Stargardt's disease that we learn about. And since it's not that common, it's easy to miss a diagnosis, especially in early disease, or misdiagnose it as some other problem, which is not Stargardt's disease. So those are some challenges, and that's what we're working to overcome, make people more familiar with the different presentations of this disease and what the best ways are to diagnose it. Because once it's diagnosed and hopefully a treatment's approved relatively soon, then we can really benefit these patients. It's decreased vision really is the symptom. Whether in well-lit areas or dimly lit areas, as opposed to some other inherited retinal diseases that are more particular to dimly lit situations or bright situations where they don't see as well. Stargardt's, it doesn't matter on the lighting conditions, they just have progressive loss of vision, which is significant. Really just reassurance, and that's it. There's no treatment for it up to this point, which is why these new developments are so important. Gildeuretinol, it's a form of vitamin A that basically functions completely normally in the visual cycle. But at carbon 20, hydrogen is replaced with deuterium, and that makes the new vitamin A, the gilduretinol, very hard to cleave. And that's what's protective in Stargardt's disease. So if you have this new form of vitamin A by supplementing it by mouth, you don't form what are called dimers of vitamin A. And dimers of vitamin A cause metabolites to form that eventually lead to cell death of the photoreceptors and retinal pigment epithelium that do the seeing in the back of your eye. So this is a stronger version of vitamin A in a sense that prevents the breaking up of vitamin A, which is an abnormal phenomena, but occurs in these patients with an abnormal ABCA4 gene. So by getting gilduretinol, you have normal visual cycle function, but you don't have this secondary effect of accumulating these toxic byproducts from the vitamin A cleaving when it shouldn't be cleaving and eventually reducing vision. So this was on the TEASE-2 study, which is moderate severity Stargardt's disease. And these patients on average were pretty young, young 20s. Half were under 18, but the age range was pretty great. It was from 8 to 44 years old. So it was a very heterogeneous population of moderate severity Stargardt's disease. So they were all grouped together, but it's probably not as neat a grouping as was ideal in retrospect because TEASE-1 looked at advanced Stargardt disease, and we saw approximately a 28% reduction, 30% reduction in the progression of disease when patients were put on Gildeuretinol for 2 years. And that was a very impressive result in a patient population that you have no treatment for. Reducing progression of disease by 30% is a big deal, right? So over 2 years. And then in TEASE-3, which looks at very early changes in Stargardt disease, that also has very, very promising interim analysis results for these very young patients with very early Stargardt disease. And then TEASE-2 made up this amalgamation of everybody in between, and with a varied age range and varied findings. In some of the findings, you could have abnormalities that were as small as in area as zero point 0.4 millimeters squared, with abnormal changes, up to 6 millimeters squared. And that's a huge population of diversity there in this patient group. So basically, this patient group was selected. 40 patients received the drug, 39 patients received placebo. They received this drug over 2 years. And at the end of the study, there was a 28% reduction in progression in the patients who were treated with gilduretinol in this population of moderate Stargardt disease. That is a great result. The problem, or one limitation, is the p-value is not significant. The p-value is zero point 0.2, and you want it to be less than 0.05. And say, well, why is that the case? Because even though these curves were separating as time went on over the 2 years, and it looked like the result should be statistically significant, it wasn't. And that's because of this heterogeneous population where, due to statistics, you needed more patients in each arm to see a statistically significant result. So the trend was very promising and positive, but the study was not powered strongly enough to make that a statistically significant result, in my opinion. And that's because in this patient population of moderate Stargardt disease, moderate severity Stargardt disease, there wasn't good natural history data to know how quickly things change with what's called EZ loss or photoreceptor loss and microperimetry abnormalities, how quickly they progress. So it made the data less certain as far as how many patients you needed. And now in retrospect, it's easy to say, oh yeah, we needed more patients in this arm and that arm. But the results of the TEASE-2 study, very, very promising trend. And then when you take it in totality with the TEASE-1 results, which are already published, and the TEASE-3 results, interim analysis, it's extremely promising for the potential of this drug to decrease the damage from Stargardt disease and keep patients seeing better and longer. I think one other thing about this drug is it has an excellent safety profile. It has essentially no side effects, in my opinion. It doesn't affect the patient's dark light adaptation ability. It doesn't affect color vision. It's really an excellent drug in that it just gives benefit as far as I can tell, and we can tell from these studies, without any visual symptoms or other side effects. So, it's hard to argue with that sort of profile. Well, I mean, there's going to be more analysis of this moderate disease, Stargardt's population. That needs to happen for sure, and we're going to look into this data more deeply. At this point, this is the first pass of the data analysis for the TEASE-2 population. The TEASE-3 population, which is very early patients, we continue to add to that study patient population, and that is still, it shows this in all the patients so far. It sees them holding on to their vision for much longer than the genotype matched siblings. So basically, the siblings have the same problem, exact same genetic problem, and they weren't treated with gilduretinol. And you see how over time they lose vision, and the patients who are treated with gilduretinol and their age matched keep their vision up at an excellent level. So, you know, it's up to the FDA, right? They're the arbiters of how quickly this gets out there or whether it gets out there or not. They have to still evaluate things and see how they want to handle it beyond this point. But these data are super exciting for those of us who treat these Stargardt's patients, and we can't wait to really have it available for anyone that potentially can benefit from it.